at the end of the two femoral condyles here and should glide smoothly north and south this way, it also has to have some play east and west, okay? And that's what we can affect with just our hands. And I found that doing more of that type of thing helps mobility as much as anything in the knee. If you've got a stiff knee, do some patellar glides and you'll see an improvement in their motion, okay? Now, what else can affect the patellofemoral joint? What can make it more of a stiff area? Tight quads, absolutely. Tight, yeah, anything, tight hip flexors, anything that's gonna attach to that. What else? Foot and ankle problems. Be a little more.
Yeah.
What is that foot and ankle problem?
If you're flat-footed, you know.
Yeah, if you are a pronator and it's gonna bring you more into valgus, you're gonna have some problems with the patellofemoral joint most likely. Good. What else?
About retroversion.
Retroversion of the hip?
Yeah.
Yeah. Any of the hip stuff can play a role in that for sure, alignment wise. We talked about Q angles before, right? Can certainly play a role. How about, if anybody, how many runners, we got a few runners in here. People who get IT band syndrome, get real tight in the IT band, that can impact it. How about just something simple like swelling? I tried to work out last night. Oh yeah, I got good swelling today. That affects it as much as anything. Okay, so if you've got a swollen joint, it's taking up more space and you're not gonna have that play.
Well, previous like knee injuries or anything like that, or previous knee surgeries affect that.
Absolutely, because you're gonna have scarring, you're gonna have whatever else you've got there, yeah. Unfortunately. So there's a lot of things that we can do before we even attempt these mobilizations. We may need to stretch something. We may need to use some ice to get rid of swelling, but then that makes things stiff. So you gotta really play that out to figure out what is the best role there. Q angle, we talked about fascial tightness, all this stuff we just talked about. Patellar contact, compressive forces, full extension, there's really no compression. So if you can get somebody to full extension, that's when you want to start mobilizing them, okay? Between 30 and 60 degrees, you're gonna see, obviously, you get more of this compressive load here, so that's gonna fit tighter. It's gonna be harder to mobilize in this, but we'll practice this today. So get them into extension if you've got to do some mobilization. Muscles. The purpose of the patella is to maintain a mechanical advantage for the quad to get that away from the joint axis, okay? So peak quad muscle is at 50 to 70 degrees. So we're gonna be at about this position where we're gonna get the most out of our quad. And again, that's got to do with the mechanical advantage of the patella. Did I ever tell y'all that I had a therapist who, older, and she had all these problems with her patella. So many young females do. They took her patella out. Took it out. I've never seen that before. I mean, you're talking about a miserable knee. She limped the rest of her life. I mean, I was like, how would they do that? There's there for a reason. That's just crazy. Amazing that some people do surgery and just go about whatever they feel like that day. So dynamic stability. We've got to make sure that we've got good congruency between all of these structures, femoral condyles, tibial plateaus, patellar alignment. Then we're going to talk about all the ligament structure and everything else. So a lot of stuff going on here at the knee joint. In gait, we know that the quad is going to control the knee flexion during the initial contact. So when we start to hit onto that heel, we know we've got some eccentric forces that the quad's gonna have to do that and be timely with. So I did a study on Georgia Tech football players back in the 50s. Engineering school, I guess. They took 5 cc's of fluid. Do you know how much 5 cc's of fluid is? Not very much. 5 cc's of fluid. Injected into the knee joint and then measured their quadriceps function. 5 cc's of fluid decreased their quadriceps by almost 50% overall. 5 cc's. I can promise you this morning, I've got way more than 5 cc's on this thing, okay? So that means my quad's not gonna work as good as it should. So just think about that. If you see somebody who's got swelling in the knee joint, and you're gonna see a lot of those, think that their quad is inhibited, okay? We've gotta have that. Hamstrings control the forward swing, soleus controlling knee flexion, gastrocnemius, the foot gets flat and goes as a pre-swing, we're gonna have that push off there. Obviously, you've seen people with hip flexor contractures, little old men walking around like this. Oh, goodness, I'm not in that bad shape yet. If we've got tightness in the ITB or in the glute, we're gonna have problems there. Foot impairments, all kinds of different stuff here. Again, just different things that you're gonna see in the gait pattern, which we will talk much more about as the curriculum progresses. Nerve injuries. Perineal nerve, where is that? Physically, where is it?
Behind me.
Lateral, goes right around the fibular head. What could impact that? Direct blow, some trauma, certainly. Get swelling around that. Braces, casts especially. If you put a cast on someone in their lower leg and they have any amount of swelling and it pushes against there, you're gonna end up with foot drop. Okay, I've seen that numerous times. They have to cut the cast off and redo it or just let it be without it. That's a problem. Saphenous nerve is what on the medial side of the knee. So this is a procedure that I had when I was at Auburn. I had a Baker's cyst, which is a herniation of the synovium back here. So they had to go in here and get to that. Well, that cut my saphenous nerve. So a couple things that did, mostly cutaneous stuff, but you could light a match on my knee right here. I have zero feeling here. I cannot feel that at all. So when I kneel, it feels really weird. So if you see somebody with a medial incision, you think about that. Kneeling's gonna be difficult for them. Referred pain, somebody with an L3 nerve root problem is gonna have anterior knee pain a lot of times. S1 and S2 will have more posterior knee pain. If someone has posterior knee pain, there's very few things it can be. Most likely it's gonna be soft tissue, hamstrings, gastrocnemius. But if it's really mysterious and you can't figure out, hey, there's nothing else going on there, always look at S1 and S2, because that's a frequent referral slide for pain. And then the hip joint can refer pain to the anterior thigh and knee. Lots of stuff going on. Lots of options that it can be. Common joint pathologies, osteoarthritis, probably the most prominent, no, it is the most prominent joint for osteoarthritis. Maybe hands, but I would say knees are huge. You're gonna see a ton of total joint replacements of the knee due to osteoarthritis. I got diagnosed with this when I was in my 30s, so it's only getting worse. Rheumatoid arthritis, we talked a lot about, very much more destructive. You'll see these people as early in their 20s having total joint replacements. Again, what's the differences? Osteoarthritis, which one is a systemic condition? Rheumatoid. So that's diagnosed with what? How do you know that you have rheumatoid? Only one way.
Blood test, right?
Blood test. blood test, exactly. Now, you can look at someone and you can say, oh yeah, they've got rheumatoid, you can see the deformities and so forth. But blood test is gonna be how that's diagnosed. Osteoarthritis is diagnosed by what? Really simple.
X-ray.
And we've all had it, X-ray, exactly. You're gonna look for sclerotic changes, jaggedness, spurring, all that kind of stuff on an X-ray. Post-immobilization hypomobility. So if we put somebody in a knee immobilizer following the surgery, don't do it much anymore. I mean, hardly any at all. But we know that they're gonna get stiff if we put them in this. I remember, so, our first summer that I stayed in Auburn, oh man. So I had this surgery, and they put me in, and I had another scope with it too. They put me in an immobilizer from here to my ankle. I had to get from, if y'all know Auburn's campus, I had to get from the Coliseum parking lot up to Sanford Hall in 10 minutes on crutches. Dropped that class immediately. Did not even attempt that. Then I got a handicap thing, and I was driving all over campus at the time, so I was cool at that point. Still got like 5 or 6 tickets at the end of the year. I don't know why they would give them to me. And I just would walk in with my crutches and they would tear them up in front of them. So it was nice. All right. So if you're looking at this, you're gonna see more loss of flexion than extension. Yeah, but extension is really, when you're dealing with like a total joint or someone who has an ACL, and we'll talk a lot about ACL today, that last bit of extension is really, you don't want somebody walking with a limp, right? Flexion comes with time. Extension is something you gotta get immediately. I won't say immediately, but over the first couple months of therapy. If they don't get it, it's gonna be a whole brutal road ahead. Hard to get to full extension when it's swollen. I'm pretty hypermobile, so I kind of work against that. Quad lag. What is quad lag? You'll see that term a lot.
When we try to contract it, it like sticks for a minute, they can't quite get it there
Yeah,
yet.
and usually it's due to swelling like we talked about, or just, if they've been immobilized. But lag refers to when you ask somebody to do a quad set, and then you ask them to do a straight leg raise. You see, I can keep my legs straight. What they'll do is they may even be able to contract here, but as soon as they lift their leg, they'll see this. You see the bend in my knee? That's quad lag, okay? And again, usually that's due to something post-operatively or a period of immobilization. But quad lag is a big problem. You've got to make sure we address that. Now, how would you address that? As a clinician who knows lots about exercise and modalities, etc. If I got somebody with quad lag, the first thing that I'm thinking about with them is E-stim. I will slap Russian or neuromuscular on them immediately and say, this is the way I want you to contract this muscle. Now lift it. Because we're helping to recruit that, they usually can overcome it. And a lot of times it's a thing in their brain that, hey, I can tighten it, but I can't hold that contraction. We've got to reinforce that. We talked about impaired balance on Monday, how that is affected through weakness and hypermobility and all this type of thing. It's very real. You're gonna see plenty of folks post-operatively that have balance issues. And until they get stronger, until they get more mobile, that's gonna be an issue that you have to deal with. Decreased weight bearing, again, you're not gonna see that much anymore. Is there a condition you can think, I'm gonna do this all day for you. Is there a condition you can think of for the knee? The only one I can think of was a meniscal repair or like a microfracture where they actually will say non-weight bearing at this point, or partial weight bearing. Everything else pretty much is get them up and going.
Is that the tibial plateau?
Yeah.
Yeah, pretty much.
Yeah.
Well, I mean, I've had, non-weight bearing. Well, there's some with a meniscal repair, like, they can weight bear, but it's only within like extended.
Right.
That's the only one I can think of.
Yeah. So So you're gonna see less and less of the non-weight bearing and partial weight bearing, but it does occur in a few things, and we'll talk about those later today. Let's move on.
Dr. Logan,
Yes,
going back to the quad lag.
Yeah.
I had a patient last Friday, and she was a total A, and she was a few, like, I mean, I don't know exactly how long, but she was doing good.
Yeah.
like, in therapy. And the last thing we did was like tandem walking on like just on a straight line, and she would have trouble like getting her leg to go. Like she would get stuck, and then it would like go. Is that what that is? Like she did that like a lot, and
So-
she had to start over.
you guys know what tandem walking is like walking a tightrope. So something like this, she struggled.
And she would have a hard time getting the injured leg like in front,
In
and
front.
she would eventually do it.
No, I don't know, it might just be just a hesitancy on her behalf, balance-wise. Was she a little bit older?
Mhm.
Yeah.
Yeah.
They don't like putting their feet together by any means, because they know
Yeah.
they're gonna wobble with that.
See, everything else looked fine. that she
Yeah,
was doing.
I think that's
Just
probably just her,
balance.
her balance and hesitancy there that would preclude that. But, the quad leg is pretty much exclusively, can it do a straight leg raise and maintain that full contraction? All right, if we've got somebody that's got a really, really stiff knee, and we need to protect it in this management protection phase or whatever, control the pain and protect the joint. Again, I'm trying to think of more examples with this kind of thing. Doesn't really happen a whole lot. More along the lines of get them up and get them moving. These grade 1s and 2s glides and so forth, we'll talk about today, teller glides. Setting exercises, what are those again? Isometrics, okay? So a quad set is a setting exercise. You can have them here, just contract here. Is my patella moving when I do that? Damn sure better be. So it's gonna help prevent those adhesions. Again, fluid exchange in here. What other isometrics can we do in this position? Can we do a hamstring isometric?
Mhm.
Yeah, absolutely. I'm doing one right now. I'm still not moving my joint, but my hamstrings are active here. That's fine. Could you put a bolster somewhere and have them do a hip abduction, adduction? You can certainly do those things. So, even if someone's in an immobilizer, you can still have their muscles start doing some things. That's probably gonna be important. All right, so we can get a little bit more aggressive. Again, educating the patient. Justice came to my office earlier today talking about the practical, and he took the sample practical and put some stuff out there. And what I want you to understand about the upcoming practicals, I know everybody's freaking out about that, is there is almost an infinite number of right answers to a lot of these questions that we have you do. If we say, we need 2 stretches, we need 2 strengthening. The most important thing you can do is right here, educate, okay? Tell them why you're doing it. Tell them, hey, don't do it this way because I want you to do it this way. I don't want you to do it that way because you're gonna hurt yourself, or this is not right, or whatever the case may be, and we'll go over that scenario. Decrease pain from mechanical stress. So look at her position right here. If you've got a stiff knee, what do you think about prolonged sitting, driving, sitting at a desk all day? It's gonna be miserable. They're gonna be so miserable when they get up. I can tell you from firsthand. I was writing your midterm for 251 the other night, and I sat there and ended up sitting there for like 2.5 hours, and I finally got up, and it was just like the first 3 steps I took were just horrible. Once I got going, it was okay, but you gotta get them up and move them around. I'm very guilty of that. Increased joint play and range of motion. Again, we're gonna work on patellar glides and range of motion exercises, stretching techniques. We can always do some stuff with this. Supporting muscles, strengthening. You've heard me say it before, But if someone's got patellofemoral problems, where do we want to strengthen besides the quad? Glute. Glute. It never fails. If I am working with someone and strengthening anything around their knee, I'm going to work their glute as well. Because if you don't work their glute, they're going to fall into this valgus here, okay? And we know that that's problematic. That's going to be a problem on the joint in terms of more compression medially. You're also going to put stress and strain on these ligaments that we're going to talk about later. So getting the glute to work as well, okay? Really vital to all of this. Okay, indications for total knee arthroplasty. And you'll see these abbreviated as TKA or TKR. Okay, total knee arthroplasty or total knee replacement. Advanced osteoarthritis. So, has anybody had a parent? Anybody that's had? Yeah, all right, so when did they have their total joint? What age, roughly? 57. 50-some.
My grandmother had both her knees done at 62, I think.
62.
My stepdad had his done yesterday,
Ooh,
and I think he's 57.
ooh, yeah, so late 50s, so I got a few
Yeah.
more years, but, so why don't they try to do it before that?
So weight bearing, there's the wear and tear.
Wear and tear, so these components, what components, what kind of things are total joints made of? All kinds of stuff. You got stainless steel, you've got ceramics, you've got composites, graphites, all kinds of stuff. But with prolonged weight bearing and activity, you're still gonna get friction and these components are going to fail eventually. Now, some are better than others. The reason that they try to put people off into their 50s, 60s, and so forth is that most of the time now the components average around 15 to 20 years, depending on their activity level, okay? So that's why I'm trying to make it to 60. If I can get to 60, I can get 20 more years, I'll be fine, I'll be good. I don't have to have it again, hopefully. Of course, my luck, I'll live to be like 100, and I've had like 3 of them. But yes, these components do fail eventually. And sometimes they fail quicker than others when they don't align properly and all that stuff. And that's all up to the surgeon. Okay, you got to get somebody that lines this stuff up perfectly. Yes.
20 years about average for all the weight bearing replacement part.
15 to 20, yeah. It's gotten a lot better. It used to be 10 to 15 when I was in school. Now it's 15 to 20. All the components are getting a little bit better. I mean, but some of the other stuff, like we talked about, like a radial head and things like that, if they're not doing a bunch of weight, but that may last forever.
Okay.
So, total shoulders and things like that, you know, they usually last longer because they're not taking as much weight bearing. So, what all this means here, all these indications, is most of the surgeons are just going to say, you have osteoarthritis. We know this. Why don't you come and check in with me every 6 months, a year for medications or whatever. But you're just gonna tell me when you can't deal with this anymore. What are some things that, besides just miserable pain, night pain is the one thing. If they can't sleep, it's time to get this stuff done, okay? But that's what you're gonna see. They're just gonna try to put it off as long as they can. Justice, you said your grandmother had both of them done at the same time? Okay, lots of controversy there. Think about that. No, someone said, no, why would you do that? Well, you only gotta go through one anesthesia. That's one good thing. And your rehab is your rehab. So if you can get it going and get through it and be motivated and all that stuff, you really only have to do it one time. Yeah.
I've had a patient come in and she had total knee surgery. She was going to get the other one done.
Yep.
So they would go ahead and start rehabbing the one that's going to get finished while she was rehabbing the other one. So that
I've seen that too. So there's a lot of controversy there. Yeah.
And also at my clinical, we have a bilateral total knees. And like they were telling me, I think she's 6 weeks out, but one knee is 6 weeks out and the other one is like 4 weeks out.
Okay. So they did it within a couple weeks of one another. Yeah, I think about that too. I'm like, should I just go ahead and get them both done at the same time?
if you don't take therapy seriously, then you're.
That's the biggest thing, is you've got to make sure, because, I mean, think about it, you don't have a good leg to stand on, so to get the range, to get you up and moving and all that kind of stuff, you gotta be pretty motivated. I think for most part, the better shape that you're in beforehand on something like that, the better off outcome they're gonna be. Was your grandmother in pretty good shape?
Once, when she got it done, she was in a lot better shape than she was even like a decade earlier. She was really overweight for a long, long time, and then when she got both of them replaced, I think it took like, I don't know, a few months of her doing the rehab, and like we bought her a glider chair and stool, and she would sit in that and pull to rehab her knees. But yeah, getting up walking was probably the hardest. That's the hardest thing to convince her to do to feel better.
You know, and the surgeons do such a lousy job of telling people what this is gonna be like afterward. And that's really our job. You know, they're blind. They think, oh, I've got the total knee, I'm good to go. The hard part's just starting. Yeah.
I was just curious, like when you're rehabbing a bilateral total knee, do you do as much of an emphasis on gait training? Because I imagine their gait's really
awful. Their gait's awful. No, I actually, if I've got somebody that has both knees done, the main thing that I'm emphasizing is range of motion. Because if we don't get it right off the bat, it's gonna be a struggle, and it's really hard. The more time that goes past that they don't have the range, the harder it gets.
Yeah.
That's just me. Would you agree with that?
Yeah.
Range.
I would say that you should at least be at 90 degrees by 2 weeks.
Yep. And you need to be at 120 by 6 or 7, maybe even 5 or 6. Yeah. 120 is kind of the magic number. If you get somebody to 120, they're good. They can do pretty much everything that they want to do.
That's pretty functional.
So you're going to see, go back to this for a second, you're also going to see a lot of people who get referred. I hope you see more of these, because I think you can make a difference with these folks. That you'll see them before they have the surgery, which is great, because you can show them their home program, and they can be doing these things before they even start surgery. Sometimes they can even put surgery off a little bit if you really do a good job in protecting their joints and making things stronger around it. So prehab is really important, and don't dismiss that at all. If you get a chance to work with somebody beforehand, please give it all they have, okay? Do all the exercise that they can do beforehand. It really will help. All right, so here are, I know we watched a little bit. What did we watch before? We watched the hip, didn't we?
Yeah.
Yeah. So the total knee is even, let's just
The way they maneuver that knee out of there,
This is so much fun.
I think the worst part is
The sound.
Hey, guess what? That's what I heard the sound is.
That's what my dad said when they had to put the rod in my knee. He said,
Let's see.
standing there watching them.
But I just sent you guys with me a picture of what the actual components look like. So you can see the top portion is that's supposed to be the femur, and then the plastic part, that's gonna be your meniscus part, and then the bottom part is the top of the tibia.
All right, so this one's kind of what to expect. This is good. I would encourage you to go watch a live one. There's very little blood because they'll put a tourniquet on them. They will tourniquet here, so when they open this up, I mean, there's like 2 cc's of blood. That's just all the blood loss for a total knee. And they take usually, what, 45 minutes or so?
Yeah, they're quick.
Bang. I mean, they have all the components and the prosthesis sitting right there. They know what they're gonna do. Come in here, pound, pound, pound. Human carpentry.
I had a lady with a total knee, and she had swelling all down the left side of her leg, like down it. Why is that? Instead of just where the tourniquet was.
No telling.
I've had people have it on the bottoms of their feet.
Yep.
And it's just completely black and blue.
Yep. Looks like
How the
someone
body
just.
reacts.
total knee replacement, also known as total knee arthroplasty, involves removing damaged portions of the knee and capping the bony surfaces with man-made prosthetic implants. A total knee replacement repositions the knee into proper alignment and replicates the original function, allowing for a near normal range of motion. Common reasons for undergoing a total knee replacement include severe pain, stiffness, chronic inflammation, or degeneration that limits everyday activities, pain that interferes with sleep, and mild knee deformity such as bowing inward or outward. Although knee replacements provide excellent results and patient satisfaction, they are typically reserved for patients who have exhausted other options in order to minimize the need for future revision procedures to repair or replace worn components. Three major components comprise the knee joint: the femur, the tibia, and the patella. The patella is a rounded triangle-shaped bone embedded within the quadriceps tendon above it and the patellar tendon below. The two large knob-like protuberances at the base of the femur, called the femoral condyles, form the top of the knee. Weight-bearing portions of the condyles and the top of the tibia are lined with articular cartilage, a type of tissue that minimizes friction and prevents damage to the bones during movement. The knee's side-to-side motion is stabilized by the collateral ligaments, and the cruciate ligaments prevent excessive back and forth motion while allowing the knee to flex and extend. A wide variety of knee replacement implant designs exist. In general, they are made of metals, including titanium, chrome, and cobalt alloys, and zirconium alloys, and synthetic materials, including dense polyethylene plastics and zirconium-based ceramics. They are usually oriented such that the metal moves against the synthetic material to minimize wear from abrasion. The femoral component is most often a curved metal cap that emulates the shape of femoral condyles and has a groove in the center that allows for patellar movement. If the patella needs to be resurfaced, the rear articular surface is removed and typically replaced with polyethylene. Tibial components vary considerably. Some consist of a metal cap fixed to the tibial surface or a metal plate with a stem that inserts into the core of the tibia. The stem may either be cemented in the bone or designed with a porous surface that allows bone ingrowth to seal it in place. A synthetic bearing that articulates with the femoral prosthesis is generally positioned on top of the metal surface, although some designs don't have a metal plate and instead affix the bearing directly to the tibia. The tibial bearing may be either a fixed or mobile bearing. Fixed bearing implants are secured to the tibial platform, whereas mobile bearing implants move on the base, allowing for a limited amount of joint rotation. A stem mechanism that prevents excessive forward motion is present in many designs, particularly when the posterior cruciate ligament is removed during the procedure. Designs for use in procedures where the posterior cruciate ligament is preserved have a space through which the ligament passes. The conditions of your knee ligaments are among factors that help your surgeon determine whether to retain or substitute your PCL. Your surgeon will help you choose the best available design for your knee condition, age, weight, gender, and activity level based on their experience with particular designs and surgical techniques. Prior to the procedure, detailed x-rays will indicate the extent of knee damage, whether any shape irregularities will need to be corrected, and will help with preoperative measurements. You will be positioned on your back for the procedure and may undergo general anesthesia, in which a gas puts you to sleep, regional anesthesia, in which a small tube called an epidural catheter delivers medication to the spinal column, numbing you from the waist down, or a femoral nerve block that numbs the surgical region. A tourniquet may be applied and your knee will be free to be placed in a bent position to enable access to the joint surfaces. Once prepped, a total knee replacement procedure generally takes from 1 to 3 hours to complete.
Less than that.
Surgical details vary by procedure and component design. Some procedures involve computer-assisted 3D imaging and micro-robotic instruments to aid in removing damaged parts of the joint. while other procedures use manual instruments with precision guides. An incision will be made on the midline at the front of your knee. Minimally invasive procedures use a 4 to 6 inch incision, whereas open procedures, as shown here, traditionally require a 7 to 10 inch incision. Next, the surgeon accesses the joint. The patella is moved to the side to provide access to the femur and tibia, and any bony outgrowths along the margins are removed, as are the menisci between the femur and tibia, the anterior cruciate ligament, and the posterior cruciate ligament in procedures where the PCL is not spared. Cutting blocks or guides are fixed to the femoral condyles. Retractors hold tissue away from the joint and protect the collateral ligaments and patellar tendon when the bones are cut. Using the guides, the surgeon makes precise cuts to remove degenerative portions of the femur and sculpt the ends to accept the femoral prosthesis. Next, a tibial guide is positioned to accurately remove a small portion of the tibial surface. If the patella needs resurfacing, a series of similar steps are used to remove the damaged portion and prepare for the implant. For tibial components that involve a stem, the channel in which the stem inserts into the tibia is now created. Next, the permanent femoral, patellar, and tibial prostheses are positioned and secured in place, and any excess material is removed. The bearing surface is affixed to the tibial plate to complete the repair. Finally, the various layers of tissue are repaired with dissolvable sutures, and the skin incision is closed with sutures or surgical staples. A bandage will be wrapped around your knee, and you will be taken to recovery. You will normally be given blood thinners and may wear compression stockings to reduce the possibility of clots after the surgery. Pain and discoloration following the procedure are common and will subside in time. Most patients will be ready to return home in 3 to 5 days, and you will be advised to begin physical therapy as soon as possible. Non-absorbable sutures or staples are typically removed within 2 weeks. Full recovery to the point where your knee functions and feels much better than before the surgery generally occurs between 3 and 6 months.
Not all the blood and gore. That's a pretty good summary. Why don't we take